Thank you so much, and thank you for the opportunity to be here. So we're going to talk a little bit about some of the background information today and hopefully answer some of those questions. So today we're going to talk about some of the unmet need for mantle cell patients. Even though we've made a lot of progress, we still have patients, unfortunately, that go through our treatments that are currently available and progress, so we need new treatments, but we're going to talk about some of them that have been developed more recently over the last few years. So the treatment landscape, you can see this slide shows some of that. Obviously, we've talked about mantle cell, and you know mantle cell is a rare subtype of B-cell non-Hodgkin's lymphoma. Represents only about 7% of adult onset non-Hodgkin's lymphomas. Some countries might be a little more, a little less. Median age is in the upper 60s, but certainly can be in any adult patients, typically seen more in males than females. And the mantle cell likes to occur in unusual places, so GI tract, around the eye, bone marrow, of course, very unusual places in some patients. Survival has improved over the years with our treatments that we have, but unfortunately in many patients it continues to relapse over many years, and sometimes very, very late relapses. So for treatment overview, typically in the past we've done very intensive chemotherapy plus rituximab, of course, in more recent years, followed by autologous transplantation. With some of the newer treatments, this is done much less frequently that we'll talk about today. Bendamustine and Rituxan, perhaps in the older patient population for first-line treatment, as always in the past, again, been a very common treatment. More recently, some of the newer data that's been presented by the German Lymphoma Study Group definitely has probably modified what we've done over the last couple of years, a little more recently in those patients. For second line and beyond, fortunately, BTK inhibitors have been discovered, and more recently, anti-CD19 CAR T-cell therapy. We certainly have some of the other ones, such as lenalidomide-based regimens with rituximab, and then more recently, some bispecific antibodies. So we're going to talk a little bit more in depth today about some of these newer treatments that we have for our patients with mantle cell lymphoma. So mechanism of action of BTK inhibitors, obviously this pathway plays a very important role in all B-cell malignancies, particularly in mantle cell lymphoma and other types of B-cell malignancies. This binds to the antigen and activates BTK through phosphorylation. And once activated, BTK transmit the signals that would promote B-cell growth and differentiation. So B-cell mechanism of action would be to try to block that, so BTK phosphorylation blockage, which is essential for all BCR signaling. In that respect, we're trying to induce apoptosis or programmed cell death, and to be able to, therefore, kill the malignant B cells. BTK inhibitors also interact with the tumor microenvironment in ways to help to be less conducive for cancer cell survival and growth patterns. And you can see on the right-hand side there where we're using that to block the pathway. So there have been, of course, several BTK inhibitors that have been developed over the years. First generation ibrutinib was begun in development many years ago and approved for chemotherapy refractory non-Hodgkin's lymphoma, in this case mantle cell. But it does have some off-target effects, which of course lead to some side effects, particularly cytopenias and cardiovascular toxicity that were found in some of the early trials, particularly atrial fibrillation or other atrial abnormalities. Second generation BTK inhibitors are more highly specific, and therefore that reduces some of the off-target effects as compared to ibrutinib. And you can see in the chart there they're all covalent BTK inhibitors, and have irreversible binding to the receptor seen there. They're, for the most part, short-acting. Specificity for ibrutinib was low in that it had quite a few more off-target effects, and for the more recently developed acalabrutinib and zanubrutinib, more high specificity, which leads to less off-target effects. And they are approved in the U.S. for second line. Mechanisms of resistance are shown on this slide, and you can see that there's numerous mechanisms of resistance for BTK inhibitors, particularly in mantle cell lymphoma, you can see the BTK resistance as far as the different mechanisms with causing some target effect, dysregulation of protein expression, upregulation of the mechanisms discussed there, and also the microenvironment can be directly affected by stromal effects. So multiple ways to have resistance to BTK inhibitors that can develop over time. What are these clinical implications for BTK resistance? Well, typically there is a fairly high response rate for BTK inhibitors for these patients, but we do have progression, unfortunately, from some of these problems that develop resistance. And also the toxicity from many of the off-target effects is fairly high for a number of the BTK inhibitors, and we'll kind of go over some specifics in the next few slides. But in the original studies, in Bruton in particular, there was found to be quite high off-target effects in cardiovascular abnormalities. The more recent BTK inhibitors, less cardiovascular effects, but we still do see some off-target effects even in the more recent BTK inhibitors, unfortunately. What are these clinical implications if the patient has problems with BTK resistance? And you can see here in this analysis of a very large medical record database in the US that went over many years, so very long follow-up. 946 patients were analyzed in this that received at least one covalent BTK inhibitor. And unfortunately, a very high percent, almost 80%, had to discontinue the drug before the end of the follow-up period for toxicity and or for progression of their disease, and therefore needed other therapies. So even though these have a very high response rate, and some patients can take these for years, many patients unfortunately do either have toxicity or progress and need to have other therapies. So that leads to some unmet needs for these patients after they have failed covalent BTK treatment, either resistance or toxicity issues. And we have to find other therapies for these patients. So historically, there have not been a lot of opportunities here, and this is where our new drug development has really been particularly helpful. Poor prognostic outcomes once the patients do fail BTK inhibitors in the past. There have not been a lot of good options. Fortunately, more recently, there are some good options. So lack of treatment sequencing in the past has led to this development, thankfully. So more recent advances that we have for these patients who have failed the covalent BTK inhibitors would include non-covalent BTK inhibitor. The one that's currently available is pirtobrutinib, or Pirto for short, and that's a first-in-class, highly selective non-covalent reversible BTK inhibitor. And it does inhibit both wild-type and mutated BTK, and has been used in this patient population quite successfully. Has favorable oral pharmacologic availability and can be easily administered. It does have reduced off-target effects, and therefore the toxicity really is quite low, and patients often tolerate this quite well. There's also in the US 2 available CAR T-cell therapies for patients with relapsed mantle cell lymphoma who have failed the BTK inhibitor, and they are currently available. They both have fairly high efficacy, which we'll go over in a minute, and of course toxicity of CAR T-cell. We all know that the potential for cytopenias, infection, CRS, and ICANS or neurologic toxicity are there as well. There's manufacturing, there's the cost, there's the availability. So they, although available, are perhaps not available to all patients. More recently, bispecific antibodies have been in clinical trials for this patient population. There's currently no specific approval. However, it is mentioned in the NCCN guidelines in the United States. So sometimes we can get this for patients in the US. It does have a small rate of cytokine release syndrome or neurologic toxicities, does have a infrastructure necessary to deliver this, but potentially in the future this may be available to this patient population. So pirtobrutinib, this just shows the different target effects that we're looking at in the different types of BTK inhibitors, and you can see the ibrutinib has a lot of off-target effects because of all these abnormalities, whereas pirtobrutinib is much cleaner and has fewer off-target effects, and you can see this noted in this diagram. So in the phase 1/2 Bruton study, which had pirtobrutinib, Many patients had a durable efficacy and favorable safety profile, and patients had been multiply pretreated and all had been pretreated with prior covalent BTK inhibitors. So this graph just shows pirtobrutinib for the treatment of relapsed mantle cell lymphoma and some of the different abnormalities that we see, and with respect to the different class of agents, the binding of the agent, the half-life, and pirtobrutinib, the third generation, is quite long compared to the others, has very high specificity, and you can see it was FDA and EMA approved in 2023 for third line after failing the other agents we just talked about. CAR-T for the treatment of mantle cell lymphoma has again been developed, but is not as available as hoped, probably due to some of the infrastructure needs and patient population. There is different side effect profile, certainly with cytokine release syndrome and ICANS or neurologic toxicity, that can be seen in some of these patients, although not all, and is more complex to administer, of course, to our patient population with an infrastructure necessary for that administration. You can see there as far as apheresis, manufacturing, lymphodepletion, CAR T-cell therapy, and then toxicity monitoring afterwards, typically for at least a month after that, if not longer. However, treatment for CAR T-cell with mantle cell lymphoma, brexacaptazine solucel or Brexacel, is currently FDA and EMA approved from 2020 for patients who have failed other therapies. And also, we currently have the Lysacel that is approved by the FDA in the United States for this patient population as well, after failing 2 lines of therapy. Bispecific antibodies for mantle cell lymphoma, although not currently FDA or EMA approved, has shown some pretty good activity in clinical trials, and that's a novel bispecific antibody that's CD20 and CD3. And that has been tested now in several different clinical trials in this patient population and has found to have some durable remissions, although there's not a lot of long-term information yet. But very heavily treated patients have been treated in these particular trials and have shown good activity. Glofitamab is currently being evaluated in a much larger study, phase 3 study, the GLOBRIGHT trial, in which patients with recurrent mantle cell or relapsed mantle cell are being randomized to glofitamab versus investigator's choice. So I assume this is an ongoing trial, and hopefully we'll have information available in the future. This is currently listed in the NCCN guidelines, so it is available to some patients off study in the United States, but certainly not all patients. So current recommendations for relapsed refractory mantle cell, this is the latest version of the NCCN guidelines, which are the guidelines that we typically go by in the United States and that the insurers go by. And so preferred regimens for patients with relapsed mantle cell lymphoma, you can see the covalent BTK inhibitors, and lenalidomide plus rituximab is also a recommendation in the NCCN guideline. And then certainly other recommended agents such as the covalent BTK inhibitor, ibrutinib plus or minus rituximab is in the guidelines, although it's currently not available in the United States for use. You do have to look at other kind of older treatments, and sometimes patients fail all these treatments and you need to look at other agents. So bendamustine Rituxan is still in there, as well as bortezomib. And so there are different options to look at in your patient population depending on what they've had previously. But certainly the pirtobrutinib and the CAR T cells that we're talking about today are very important for this patient population. So in summary, patients with mantle cell lymphoma are very commonly treated now with covalent BTK inhibitors, such as ibrutinib, acalabrutinib, zanubrutinib. However, unfortunately, many patients do relapse and or have toxicity issues with these agents, and resistance develops, so they do need other agents, as we're going to be talking about today. And patients do progress, sometimes in a short order. Typically, a median time would be less than 10 months once they progressed and have very poor prognosis. Non-covalent BTK inhibitors such as pirtobrutinib and others that have been in development, as well as CAR T-cell therapies, has definitely have some good activity and provide treatment options for this patient population. Certainly there's other treatments that are currently in development, and we'll be talking about some of those down the line, but hopefully we'll be able to have these available for our patients. Thank you very much for your attention.